Hello, welcome to ADAPT NCLEX. Today we'll be talking about a little bit of ethics. These kind of questions are straightforward if you know the basics. So let's get to it. There's certain things you have to know about informed consent. As you can see from the name, it's basically you are informing the patient about what you're going to do. And there's some principles that need to be satisfied. Informed consent refer to a procedure going to be done. And usually the person who's going to do the procedure is the one who get the consent. And you need to explain it to the patient exactly what he's going to do. So it's the surgeon, number one, the surgeon that obtain the consent. The nurses don't obtain the consent. So it's the surgeon who obtain the consent. And what the surgeon need to do is there's a couple of components that you need to satisfy when he's obtaining the consent. He has to give a clear diagnosis of the problem, the risks and benefit of whatever he's going to do, if surgery or he's going to put some line in it, central line or whatever. And then what is the outcome? The outcome is very important. And of course, everything you have to ask for alternate. Is there any alternative option that we can take instead of doing this procedure? So alternative information should be given by the doctor that if you don't do this, this is what is going to happen. And if there's an alternate, what are the complications of each of them? And so that the patient can decide what they want to do. So this portion forms a large portion of the consent. And like I said, is obtained by the surgeon. The client might indicate understanding. He should, not even must indicate understanding of everything that was done. So he has to understand it. And this information has to be in layman's language, simple layman term that he understand exactly what you're going to do. They cannot be forced. It should be obtained voluntarily. You cannot just tell them exactly what you're going to do and then you expect them to accept it. They have to decide what they want to do. That's why it's called informed, and they consent to that. Even if they sign the consent, they can rescind it as soon as possible. The day of surgery, the day of the procedure, they can do that. And of course, you can't do anything without the patient being competent. So you can't do that. They shouldn't be they should be competent. And what does that mean? That's the big word over there. Okay. A competent person is not under influence of anything. So he can make a decision using his mind, but he understand the risks and benefit, and there's nothing in the system that is affecting his thinking. His faculty is not affected. So he's not under influence, like he's drunk or he has received medication. This is what they like, medication, like morphine, any narcotic, anything that can affect his central nervous system, depression, he can't take it. So no Valium, no morphine, nothing. So before they come into the preoperative area to get it for procedure, you make sure they sign the consent before you give them any medication, even if they're anxious about the surgery. No anxiolytic, no pain medication until they've signed the consent. So they cannot be influenced on anything. Otherwise, that consent is irrelevant. After they sign the consent, you cannot modify it. Can't modify the consent anymore without the patient knowing. If you have to modify the consent, this is what you do. So if I write something here and you want to cancel, you just put a line through, straight line, just one straight line. Everybody can see what it is. And then you sign, you put your initial and the patient sign below. That's all. You cannot, if this is maybe surgery, you cannot do like that and just basically scramble everything so that nobody we'll see what is under it. That is unacceptable. The next responsibility. So what is the next responsibility? Don't obtain consent. You just facilitate the consent. You need a consent before the patient will go to surgery. So you will make sure there's consent. So you talk to the patient, you talk to the doctor, and call the doctor to come and obtain the consent. Your job is to witness. That's all. And I know they always ask, why am I signing this? They worry that they will be, if something happens, they are responsible for that. You are not responsible for no legal responsibility at all. Like if there's a complication, you're not going to be responsible for that. All you making sure is the patient understands what is being discussed to the patient. That is all you're witnessing. You're witnessing that the patient understand the information provided. So if something happened and the patient said they don't understand, yeah, that aspect of it, you are responsible because you have to make sure they understand, they are not under influence, and they verbalize. And the last one, you cannot obtain consent after surgery. Patient on the day of surgery, even when they have to move them into the operating room, they can say, I don't want to have this anymore. I am done. No surgery. You cannot push them into the operating room. You said, okay, thank you very much. We'll see you back again in the clinic and discuss further treatment. That means, no, I don't want it. That is the end. No more discussion. You say you see them in clinic and you cancel the case. It doesn't show any weakness, nothing like that. Okay, everything in life, there's exception. Okay, so what are the exceptions of what we talk about? That you got to obtain all these consent. Sometimes if the person or whoever is involved is emancipated, so less than 18, but they acting like 18. That's what it means, like emancipated minors. So they are 18, they are less than 18 years old. So they cannot be classified as adults. But these people can consent, okay? They can consent on their own without any problem. Okay, you have to be 18 to be able to consent on your own. But there's some people that cannot. They are less than 18, but they can do that. So if they less than 18 and you're married and you have a child, yes, you can do that. You can consent without any problem. There's some 17-year-old in our military, military service. They can do that. Without any problem. And if you don't depend on your parents, so independent, emancipated minor, so you can consent on your own without needing any parents. I think the number one that you have to know is emergency situation, okay? You can come in with like subarachnoid hemorrhage, the severe headache of your life, or if you're in coma, severe head injury, okay, and there's nobody around, we can treat you as a form of, we call implied consent. So when you hear the word implied consent, means you would have allowed me to do that procedure. You will have consented for that procedure if you are able to do that. Right now, you have severe arachnoids, severe problems, severe subarachnoid hemorrhage. You have head injury. You can't make informed consent. We can see that as implied consent and try to treat you before you die. And then there's some certain situation involve some minors, okay? Like minors, okay? They are not emancipated though. They are not emancipated. These people, if you emancipated minor, is like they're less than 18, but they married, they have child, they are in service, and they're independent. You can just be a minor and you still consent for a procedure, like if it's for ST, sexually transmitted infection treatment, yes, you can get it. You don't need any consent from your parents. Okay. If you're getting oral contraception, you don't need any consent from your parent because you are less than 18. But this specific category, you are allowed to get your own consent without any problem. If you need a mental health treatment, yeah, your mommy doesn't, or your father that cannot consent for that if you're less than 18. If you're more than 18, yeah, you can do whatever you want to do. So less than 18 and you need mental health treatment or you want to go for a rehab, yes, or maybe drug abuse treatment, fine, we'll treat you and we'll take care of you. Okay, so those exceptions, I need you to just put them in a category and try to remember them. A minor, emancipated minor, and emergency situation. There's a caveat though. You have to know how it flows, okay? So this is what I call it, the flow of consent. So consent flow. Patient come in and then they need a procedure done. Well, the doctor will obtain consent, informed consent from the patient, right? So that is usually the actual thing. Normal, somebody more than 18 years old, he can do that, yes. If the patient cannot consent, okay, and he's a minor, he cannot consent, he's a minor, and it doesn't involve any of this. It's not sexually transmitted disease or oral contraception or mental health problem or drug abuse. It's just surgery. He can't consent is on his own. He needs somebody to consent. The parents are responsible. Okay. You have to try to reach the patient, the parent. There's a couple of scenarios they can trick you. If the parent present, okay, parent present, well, you got to ask them for it. So ask the parent. And the parent cannot refuse for a life-saving technique. So it can't refuse treatment for life-saving for their kid. Okay? They can do that. If the parent refused because of their belief, like patient need the blood and the parents are Jehovah's Witness and said, no, I don't want your kid to be, my kid to be transfused, even though the kid is anemic, then this is a life-saving technique. We have to go to the hospital. So we go to the hospital, legal will take over and they go to court and get a court appointed guardian to take care of the procedure. So that's how it flows. One is if there's nobody around and the kid came in and there's nobody, 13-year-old, the same thing. Nobody around, no parents, nobody. Well, if there's a grandma is there, ask them if she's a legal guardian. So ask the grandmother if she's the legal. Or basically the one in charge of making legal custodian, basically. She's going to be making all the decision. Then she will give you the information to do that. If she's not, and she said, oh, mommy is the legal guardian, or mommy, try to reach mommy, try to reach by phone as much as possible. And if you guys can't, you cannot reach them, then proceed because the kid need life-saving technique. This is different from implied, okay? They need life-saving, but they're not dying, okay? Like probably the kid has appendicitis or he has a cut in his leg that you need to do something. It's life-saving, but it's not in the verge of dying. It's not a true emergency. You have time to do something, yeah, then you proceed with that. So that's how this is how they trick people with this kind of question. But you have to have it in the back of your head. Don't let them trick you. This is the pathway you go and don't distract the pathway. I mean, you let it be, that's the way Of course, if there's nobody, you call nobody, you can't reach anybody, you proceed with the procedure. Well, if an adult who is competent, if they need a life-saving procedure, and if they're competent, they can refuse. If you come in and you're having heart attack, and I tell you that you need an aspirin, we need to take you to cardiac catheterization to open the vessel that is blocked, and you're competent, we confirm that you're competent, and you refuse, we cannot do anything. You can refuse. A competent patient can refuse life-saving technique, except, once again, this is why this topic is a little bit confusing, except the same thing, except if you are suicidal or homicidal. Okay, if you're going to kill somebody or you're going to kill yourself and you're refusing, I'm not letting you go. We are not letting you go. Advanced directives. This is very important. This is life. Okay, you get to a point where things happen and then emergency. Life is, we don't know happens. You have a car accident, you get older. So sometimes when people make decisions, that's why it's called advanced. The word advanced is like I told you, scientists don't know how to name things. So advanced is ahead. Okay, directive, letting somebody instruction. So this is the instruction you've given ahead. This is what I want it to be done when so and so happened to me. So you prepare it ahead of time, not at the last minute. There is two types. There is a living will versus power of attorney. I like to use only one. They can use AirCare proxy. It's fine. AirCare proxy, I mean, whatever. I like to use one. And if it's not living will, it's the same as AirCare proxy or power of attorney. They will use different names for it, but they are the same. Okay, so yeah, I'm using power of attorney. There is specific information about each of them. Okay, the living will, you make all decisions making by patient, client ahead of time. And there is basically no room, okay? There's no room for you to change anything. There's no flexibility. I think that's the right way. No flexibility. You can't change anything. You make a decision and you tell everybody, this is what I want. I don't want to be intubated. I don't want any feeding tube. I'm giving you an example. They will say it specifically. They will write it down. This is what I don't want. This is what I want. This is what I don't want. If we come to that point. So all decisions is already made by the patient and everybody needs to stick with it. Okay, nobody can change it. Nobody can modify it except the patient. He can modify it anytime. It's not set in stone. Okay, it can be changed by patient. The patient can make that decision to change it. So this is very, very important. The second one is power of attorney. Basically, there's flexibility. No decision is made. Patient said, he appoint, we call it proxy. Please make decision for me. Somebody you trust, your friend, your family member, you said, if something happened, make that decision. How we imply it, that person is going to make a decision that we think the patient is going to make it. So the person you appoint, the proxy, is going to be your advocate. Is making a decision for you that he or she will assume that that is the decision you will make. You don't tell them anything. You don't discuss anything. And they will say, if we were able to do that, this is what so and so will have done. So that is what etiquette. Try to separate in your mind. That decision is coming from the proxy that is assuming because he's been with that person and the person trusted him to do that decision, that he will make the best, most important decision for me when the need arises. So that's why you dedicate everything to that proxy. Okay? Living will and proxy, like I said, you can change it anytime. You can change the proxy, you can have multiple proxies. That is fine. Okay, you can change it last minute. Okay, no problem. But nobody should solicitate for a change. I wrote in the capital letters. The nurse cannot ask you to change it. The doctor cannot ask you to change it. Nobody should solicitate you. Hey, you need to change it so that we can do this. No, nobody. If you made up your mind, that is it. So if you see as a choice like that, it's a distractor. They're distracting you. You know the patient is sick, and so why don't we tell him it makes sense to change it so that we can do the procedure and he can live longer? No, that's wrong. Absolutely wrong. You shouldn't do that. All these documents are legal documents. So you got to do some teaching. Keep them in safe place. Give copies to give copies to the proxies. Why not? And make sure it's in your keeping medical record. Please don't keep it. Don't keep it on top of the refrigerator. Or put it inside the refrigerator, like some people do, or under your, what is the best way? In your car or something, that is not safe. It has to be kept in a better place. You don't need any to notarize it, okay? But you need two people to sign it, two signatures, two witness. And this is where they trick you. The proxy cannot be part of it. No proxy should sign it. No HCP should sign it. No nurse should sign it either. Other people has to sign it. They cannot be involved. You got to get all these facts. And then when they give you a SATA question, you just know at the back of your mind, you just bring it back and specific. There's no ifs and buts about this law problem. This is ethics. So you have no room for error. DNR, okay? This is completely different from living will and PO and power of attorney, because this usually, it doesn't apply the DNR when you are outside the hospital. So if something happened to you and you don't want to be intubated, you need additional one. So you need to get this done and different DNR so that it can apply. So you go another place where you get a DNR, do not resuscitate or do not intubate form, and you get a bracelet, okay? So that when something is happening to you and the EMS come to your home, they just look into on your wrist and they see it, then they will do it. So this living will and power of attorney doesn't apply in that situation. Like if you have a car accident, they see you on the car accident, well, they won't go into your record to go see that. So you need additional information. That's the DNR, DNI information where they fill the paperwork, and that one you have it with you, and you get a bracelet that indicates you do not resuscitate this patient, and everybody need to stay with it. And I think this is exhaustive on that advanced directives. Don't mix them together. They will try to trick you. They try to trick you as always, but try to stay within the program. This is what I know, and I'm sticking with it. You need to be admitted, and you said, no, I don't want to be admitted. Yes, you have the right to do that. So you have the right. You have absolute right for that. Right for refusal of admission. You can refuse the admission or treatment, okay? But we cannot let you go if you are suicidal, homicidal, okay? If you're going to kill somebody, you're going to kill yourself, and you can't take care of yourself. So from Maslow, if you can't do your physical needs, we admit you. If you come in, you are like schizophrenic or bipolar, mental health, and you so down, depressed, and you can't even drink, or especially schizophrenic with who's in catatonic. In the catatonic state, they can't do anything, they can eat, they stay in one place and lay down or screwed up. We will not let you go. We're going to admit you. So these are the key things you have to have in your mind. Suicidal, homicidal, and not being able to take care of yourself. That is, you can't fulfill your Maslow criteria. Then we are admitting you. Then guess what? Okay, we back to square one. If we admit you back to square one, you can still refuse treatment. But at least we've admitted you. But if we think this is still life-saving, what do you think? Next step, we go to the court for permission from the judge so that we can treat you. And that's where we can feed you. We can put the NG tube in. They can restrain you. You can put things in you, and then they will be able to treat you. So there's something we call against medical advice. So this is the thing. Patient coming to the hospital, he needs something to be done, and he's been admitted for a couple of days or right away. Then he decided, I'm leaving. I'm packing my bag. I don't want any more treatment. I'm leaving. So we call leaving against medical advice. What do you do as a nurse? You know they need antibiotics. They need to be treated. They have cellulitis. I mean, you are already admitted them. That's why they want you to do it. Then they're leaving. Like I said, the principle, stay with it. Patient still can refuse. So he refused. He said he refused. He want to leave. Well, assess them for competency. Call the doctor. And then doctor come and let them sign. You don't give them the form to sign. The doctor will give them the form, the legal document form to sign for AMA. If they don't want to wait for the doctor to come because they are in a hurry, well, let them leave then. But at least you've documented. Yeah, let them leave. But you have to document that. You call the doctor is coming, they still want to leave. Well, you let them sign the consent and then leave. But everybody have to witness that they're leaving without medical this thing. Just because they're leaving doesn't mean you treat them like garbage or something like that. You have to provide something we call, if there's informed consent, we in medicine we call it informed refusal. So there's an informed consent and there's an informed refusal. You tell them you're leaving. If you leave, this is what is going to happen to you. You're going to get sick, temperature and everything going to go up. You're going to have this and this and this. These are the complications that is going to, you list them. But then you say, but if you see them and you want us to treat you again, please come back. Please come back. You give them the option to come back, because that's what we do. We take care of patients. We don't just throw them away. So you tell them, come back and we will still take care of you. So that is the gist of against medical advice. Expect to get questions like that to see if you still understand the concept. They can leave because they have the right of refusal. You need to assess their competency. Then if he's competent, you call the doctor. After you call the doctor will come and get a consent, and then the patient can leave. If they want to leave before the doctor come, after you call the doctor, it's fine, but you have to document, and then you give them the informed refusal information. You have to treat them well. Point, we can't save them. They are end of life, okay? End of life. They're about to die. There's something we call death spell. They can smell like death. The patient can still smell it. They can see death coming. And so they undergo certain changes. So the changes in life, you can see it. The patient, it's not like they depressed. Death has some feeling in the body that can tell the body that it's time to go. So you don't want to be feeding a dead body. That's the way I understand it. It may sound a little bit weird, but something that is dying doesn't need to be fed. So the patient will become anorexic. So anorexia. This is good for them. It's good for them. It's a hard concept to understand. Family doesn't like it. So family worried. So it's okay for them. It's okay for the anorexia. Okay, it's okay, but it's hard for family to understand that. It's okay if they refuse to eat, it's okay. Because what are we talking about in end of life? Quality of life. That is all. And so naturally, the body will start shutting down and they don't want to eat. You cannot just, I remember something. Don't put feeding tube in them. They will tell you, they will put that in the answer choice. Don't do that. Don't put NG tube. No way, just to feed them. It's normal finding for them to be anorexic. So let them go in that way. Okay, this is the key. Anorexia is good. They need quality of life, and don't put feeding tube in. These people are dying, they can't move, they can't do it. Then we subject them to a big surgery. Just help them to improve the anorexia, but you can't force feeding tube on them. And then this medication for that is a stimulant. This is a stimulant, and they will eat. Okay, they will eat a lot, and then that may improve their appetite, and they will eat. Maybe you may have to look at their mouth, oral care, to wash their mouth and then get them dentition improved, and then they will start to eat. Or let them choose their food. So meal planning, they'll be involved in the meal planning so that they can also eat. Maybe they don't want the food you're giving them. That's why they don't want to eat, but they are going to be anorexic. So let them choose what will make them feel much better. Or they can eat with their family, family eating. Okay, they eat together. Maybe they will feel like home. But this is the concept. These are the only two concepts I think is a content that they would like to test you about end of life, what they do, and how to stimulate them to eat. You can't force them to do that. So there's key terminology. This is where sometimes ethics bothers some students. There's key terminology. If you know it, you know it. If you don't, you don't. There's no way they can make it. You just have to know the definition. And you can use the definition based on the way you look. So we're going to list a bunch of them. I may remember a couple of them, but the first one is assault. Okay, you are assaulting the patient. You shouldn't do that. No person, healthcare provider should do anything. Okay, that is when you an act of threat. You threaten them, but you have not touched them. You threaten them. If you don't do this, I will do this. If you don't eat your food, I will shove it in your mouth. That's not good. That's threatening. If you don't stay in the bed, I'm going to tie you down. That's an answer. You just basically you're threatening them. You have not touched them, but if you touch them, this is battery. Touch. You threaten them and you touch them. You put your hands on them. Okay. And then the other thing is forced imprisonment. Basically, you're restraining them. So like a patient is on the bed and you have two rails of the bed up or up. Okay. You can't do that. If the rails, all of them are up, you can't do that. That's battery. So you can do that. You only can keep one up. So that's a restraint. You shouldn't be doing that. Okay. Then another definition, think privacy. So invasion of privacy. So basically, you releasing record without your consent. So no consent for record. You releasing a record they have no consent. They have not given you a consent. See, so that's the problem. If you are invading their privacy. Then there's this called Veracity, I think, yeah, Veracity. And what does that mean? Veracity, be truthful. You tell them the truth, you don't lie to them. They're not going to write veracity. They're going to write a statement that represents that. So you have to know your definition alone and look at the statement if it's another way of writing veracity. So that's why I try not to use long words. Be truthful. So what you say something, you do it. You don't lie to them. That's veracity. Then accountability. That means you take responsibility. You did something wrong, you own it. You don't blame anybody. It's the patient's fault. No. Then autonomy. This is where an informed consent come in. These words before. So this is like they make their own decision. You let them make their own decision without anybody interfering. And confidentiality is almost like the same as it's a process, okay? Confidentiality means you keep their staff secret. But invasion is you have had an act. So confidentiality is you keep the thing secret. You don't share with anybody. But when you share, you have invaded your privacy. So the invasion is an act of doing it. But confidential, you don't talk about a patient in the cafeteria, in the elevator, or in the bathroom, or in the changing room. You don't do that. If you can talk among each other, if you are involved in the care of the patient. I can talk to a nurse about a patient that belongs to me. I can talk to them about the patient or the UAP. But I can't talk to the patient about radiology in another floor who has no care, responsibility, is not involved in the plan of care of the patient at all. There's no need for me to go talk to them about it. Even though they are doctors, that doesn't apply. Justice blind, you know the law. So equal justice. Everybody treated equal treatment under the law. If it's no Nonmaleficence, then the other one is benefit. The way to remember is B is beneficial to the patient. So normal is not beneficial to the patient. So this is for good of the patient. And I think the last one is fidelity. This is a little bit hard to get it. Is you have to be like fulfilling your promise, commitment. So you fulfill it. It's different from being truthful. Truthful, you're telling them the truth about things. But fidelity, you make a promise, you have to keep it. I will call your doctor to increase your pain medication. You never call. Patient still is in pain. You are not showing fidelity in that. So this is all. These are some of the words you have to know. They can put it in SATA question. They can put it in the statement form. They can want to trick you, but just stay with the short definition and translate that definition into the bigger definition, and you'll be golden. Once again, thank you for listening. Thank you for your time. I hope you gain something out of it. And visit my Facebook channel and then YouTube and subscribe for more content. Thank you very much and keep charging.